Okay, so good evening. And again, I'm Randy Kearns, your professor for healthcare management, the HCM 2000 course. And tonight we're going to hit the first piece of history of the American healthcare system. In this particular presentation, I'll go over some of the basics of how the system got to where it is today. What we'll do next week is it's also a history of the American healthcare system, but there I'll lay it out in a little bit more of a longitudinal fashion so that you can see the timeline of how things kind of fell into place or how things were created. Tonight, it's a little bit more about going over what are the key pieces, how did things kind of change, and where are we at today. As I said last week, and I'll say in this course and any other course, no one would wake up tomorrow and say, I want to design my healthcare system exactly like the Americans. You know, it's not exactly, it's certainly not perfect. It's somewhere between good and excellent, but it also depends on access and certainly where you live as to what type of quality of care you have. And again, we'll talk about some of those things tonight and throughout the course of the program. So let me be sure, first of all, the screen that you can see is my landing page on Moodle for this week for the history of the American healthcare system. Is that what you can see?
Yes.
Thumbs
Yes,
up.
we can
Okay,
see
good
it.
deal. Thank you. And just I've included a couple of links to articles that I think help offer a little bit more context to how others see the American healthcare system, and also a little bit of a look about, again, how the healthcare system evolved over the first 25 years, and really the first 25 years when we talk about the modern era of the American healthcare system, we're really talking about 1967 to 1992. And the reason for that is Medicare and Medicaid were created by law in 1965. They became active programs in 1967. And as we'll go over somewhat this week, but certainly next week, and then there's a particular night that we'll talk specifically about Medicare and Medicaid. It dramatically shaped or reshaped key things that are components of the American healthcare system. And so with that, and again, your assignments this week. So the main thing you need to do this week, I would encourage you to take a look one more time at the presentation when you have a moment to go back over anything that you may have not quite understood, or maybe I didn't cover it as thoroughly as I should have. But in the context of trying to cover this in an hour, I'm just trying to be sure that I hit the key pieces that you'll see down the road and that will be important for you as you build additional information to better understand the American healthcare system. And that the links also reinforce some of that and again give you slightly different viewpoints of that. Your first quiz is due Sunday night, so there's no discussion this week. The only thing that's due this week is a quiz. I think I give you 2 minutes per question. As the semester goes on, that time period per question will start to squeeze down. You know, so there will be other classes that you're in where professors get really wrapped up about you looked up an answer, and let's just be honest about something just a moment. If I don't know something, if I'm not sure about something, who's the first person I ask? I ask Google, you know, or I know what source to look for. And what I try to do with the quiz is I try to, again, 2 minutes, with 2 minutes, you can't look up the answer to every question on the quiz. But the main thing I'm trying to do is build a little muscle memory to help you get used to how to think about think about some of these things so that you can answer those questions intelligently and coherently. Because again, when you get out into the world of healthcare, there's a basic amount of knowledge that you need to know. And and part of it is knowing where to find it. Part of it is what you've committed to memory. Part of it is what you've memorized. Um, but again, you can't look up everything. Um, but some of the more extraneous things, certainly you can't commit to memory everything that's here as well. And so again, I just understand that I have a slightly different philosophy than maybe some of your other professors, but that's how I see things. I don't. I'm not telling you what they do is good or bad. I'm just saying to some extent it's a little bit different in other classes, maybe than in mine and others like mine. So let's kind of go through the presentation. Actually, let me um, change my screen share to this. So is the screen that you're seeing, is that the projection screen? Is that what you're seeing?
Yes.
Okay. Okay.
I also have a question.
Yes.
So the quiz that's due on Sunday, it's going to be just kind of, I mean, some of it you said common knowledge, and then some of it like maybe a little in this PowerPoint, like the lecture you're kind of going over, maybe in the links you gave, just
Everything that you see on that quiz, those answers will be found in this presentation.
okay.
Okay. So the links and the other articles that I've included, I use them to help reinforce or to offer more information about some of the things that I include in the presentation. But to be quite honest with you, all of these quizzes, none of these quizzes are, in some courses you may find what's called a store-bought quiz. The instructor gets the instructor packet from the publisher, and the publisher sells you a book, and they give you slides, and they give you a quiz bank. All of the quiz questions, all of the slides I created, um, and that's because healthcare has changed so rapidly and so dramatically. Dr. Zimmerman and I talked about it, and it doesn't make sense to me to expect you to spend $100 for a textbook that I'm going to spend 20% of my time trying to tell you what to ignore because it's changed since the time that was published. And so I'd rather develop the content myself, and because I'm a part of my job is to be sure that I'm up to date on these things, and so keeping this content up to date is also one of my responsibilities. And so that's what I do. I develop the slides myself. I develop the quizzes myself, and they reflect the content that's in the slide. And I start from the slides to create the quizzes. But there are times that, because I don't feel like I've covered the topic sufficiently in the slides, I will add additional links in the Moodle shell for that particular week to help you explore more information, to help you better understand maybe that topic. Is that helpful?
Yeah, that was helpful. Thank you.
Okay. Okay. Any other questions? So the first thing I like to start out with is why healthcare. And as I've alluded to, if we look at what happened in, actually, I think it was December of 2017, that was the first time that over all employment in the United States, the healthcare sector surpassed manufacturing and retail trade as the largest employer in the United States. Now, I'll tell you, I've taught economics a couple of times, and I have a little bit of a background in it. I'm just enough to be dangerous. I'm not an economist, and I don't play one on TV, but I can tell you there's enough of that is a little bit disturbing. But if I'm in your shoes and I'm looking for a job, it's also pretty exciting to know that, the largest potential employment sector that's out there is in healthcare. And again, it does tell you how much of our economy and how much um, of our country is really built around the healthcare sector. There's a lot of things we can outsource. There's a lot of things we can import. There's very little we can outsource and import in the healthcare world. And so key objectives that I want to be sure and cover tonight, key characteristics, a broad overview, what are the stakeholders from a population standpoint, and then the health industry trends, and particularly laws as they have changed and continue to change. The last 6 years, the last 10 years have been pretty exciting. Even during the Bush administration, there were a lot of things that were done. So, I mean, we could really go back 20 years. And as we will cover next week, we'll talk about how things have unfolded in a fairly rapid fashion between George H.W. Bush and then certainly President Clinton and his focus on the healthcare world. President George W. Bush, some of his developments, some of the things that went on during his administration, the Obama administration, which created really a fundamental shift in the way we look at healthcare through the Affordable Care Act. Again, because of how our country has become so polarized, sometimes we view Obamacare through the lens of we either like or we hate the former president, as opposed to, is it a good piece of legislation? And I have my own personal opinion about President Obama, and I think ethically he's probably one of the strongest people who served, but that doesn't always tell you what you should think about the particular piece of legislation. And there are places in the legislation we need to improve it, but to be able to do that means there needs to be a dialogue. And right now, the only dialogue that seems to take place is throwing its incendiary terms toward each other, rather than trying to figure out how to solve something. The last 4 years were spent not trying to improve something, but trying to break it apart. And the next 4 years, I don't know. I hope they're able to, again, candidly go back and look at things that they can change, but they probably can't change a lot because there are some pieces that you need to do that are going to be politically uncomfortable to do and erode some of the base that you need to get reelected. And every politician will tell you their primary goal is to get reelected. So I don't know. Anyway, that's enough of that. Other pieces that we want to talk about is technology. Technology really is this huge component, and it's also a huge cost driver in the American healthcare system. We have one particular week that we'll look a lot at technology, but there's a lot of things throughout the semester where we'll talk about how technology has really changed some of the things that we do. And there are fundamental questions. Has technology changed so much of what we do that it has added so much value? It certainly has added a lot of cost, but has it added a lot of value? And those will be things that we talk about. The charitable mission that's really evolved, I can tell you, again, about 75% of the hospital systems in America are not for profit. Just understand, not for profit and not making a profit are two completely different things. When you hear not for profit, you really need to think it's community based and therefore they don't have to pay taxes. But that doesn't mean they're not profitable. I read a daily briefing from a group called Becker's Healthcare, and again, they give you some of the highlights of what's going on in healthcare around the country each day. Brigham and Women's and Harvard Pilgrim, which is Mass General, it's the largest health system in the greater Boston area. Their fourth quarter profit for last year I'm sorry, it was their first quarter, which was October 1st to December 31st. Profit, not net, I'm sorry, net revenue, not net income. I'll get it right in a minute. Net income, not gross revenue, but their net income was over $1 billion for the quarter. And, because they are not for profit, they don't pay taxes on that. But also because they're not for profit and community based, they have to reinvest that in their operation. And advantages, they reinvest it in, if you work there, chances are you could get a raise. If you work there, chances are you may get better equipment or better technology. They'll probably invest some of that money in trying to expand their system. But just understand the historical charitable component of what we saw with healthcare 50 years ago or 75 years ago has really been replaced by profit driven, regardless of your tax status. And then these confidential relationships, so they're still there, but there are challenges to that, and we'll talk about that a little later on. There's a huge number of stakeholders. It's like any other business. You have to look at where the money is, and it's the old joke about asking a bank robber, why he robs banks, and he said because that's where all the money's at. Healthcare looks at certain sectors of patients in patient care environments also because that's where the money's at. If I took you to a hospital and I broke out their financials, I would tell you the people who focus on sick hearts, meaning electrophysiology or different types of cardiac conditions, treatments for cardiac conditions, whether it's making blood vessels that are partially occluded reopen again, dealing with different types of heart disease. That's a very expensive care. It's also financially very rewarding. The cancer treatment centers are typically financially very rewarding. Orthopedics, certainly financially very rewarding. But there are a lot of things that you lose money on in a hospital. And so you have to have those profitable service lines, so to speak, to offset some of the losses that you have in some of these other areas that you need to operate to have a complete and comprehensive hospital and healthcare system. And then the things that are going to change fundamentally the way we do things, genetics, the human genome. So much of our medicines have been developed in a manner that addresses a broad swath of the population without truly understanding how to target specific individuals. We're far more likely, when you hear about clinical trials are far more likely to have included, in some cases, more men than women, and yet more than 50% of the population is female. Some of the clinical trials are far more likely to inconsistently reflect diverse populations, particularly minority populations. We'll talk a little later about why certain minority populations are not trusting of clinical trials, and they have a right to not trust clinical trials because of some of the things that have happened. God forbid anything like that is happening today, but those are true stories and those are real stories. And so it's very difficult for people to regain trust when there's a reason why the trust isn't there right now, at least in certain communities. And again, we need to talk about that. Financially, it's an enormous industry. It's about 17% of the US GDP, and 3 trillion is direct cost. We believe the indirect cost puts it closer to 5 to 6 trillion. The US economy is about 20 to 23 trillion dollars. And the US economy is much larger than any other economy in the world. The Chinese economy is about $12 trillion. but that also gives you an idea of, and then there's no other economy that's larger than $8 trillion, but it also gives you an idea of just how much money we spend. More money on healthcare in America than all but 5 countries spend on all of their entire expenditures for their country. So we do spend a lot of money. Part of it's because there's a lot of variety in practices, a lot of different ways to do things. There's a lot of different insurers. We will talk about, although the Clinton health plan failed in 1994, a lot of what we saw with the Affordable Care Act, and again, what some refer to as Obamacare, was based on looking back at the failures of the Clinton administration to deliver a health plan. Where did they step on landmines? What were the problems that they encountered? And then how to design a system to avoid that. And again, we'll see how those successes were created based on the failures that had been seen earlier. And the Clinton administration failed doing a lot of the same thing that the Truman administration had done and the Johnson administration had done. Again, we'll talk about that next week. So the real challenge, if you look down at that second bar, the poor US population has outcomes compared with 12 other higher income nations with the lowest life expectancy and high infant mortality rates. The fact that we spend more money doesn't make us healthier. And in fact, there are a number of situations where we just, as a country, and certainly as a profession, we don't do a good job of providing equal access for everyone and equal care for everyone. As a country, we're quite capitalistic in nature, and there's nothing wrong with that. But the challenge with capitalism as it relates to healthcare is healthcare is more of a service. This is not Walmart. You know, at Walmart, when I get to the checkout item, if I've got $110 worth of items and I only have $90 in my pocket, I got to put some of it back. I can't take the things that I can't pay for. In healthcare, if I'm having a heart attack, I'm not pricing anything. I want you to save my life. And because I don't price anything, because I'm not a savvy shopper, we wind up with a lot of disparate cost and a lot of cost overruns. And again, we'll talk about some of those inexact components of the economic side of healthcare. But again, I get back to the people who have the least among us typically don't fare well in the American healthcare system. They don't get the type of care they need at the time they need it. We wind up with low birth weight, and low birth weight leads to a very expensive neonatal care and early childhood care. Again, infant mortality is much higher in the United States than it is in more than a dozen other countries. And that's beyond disappointing. Again, we'll talk about some of those things later. So the Affordable Care Act. Key components of the Affordable Care Act. So with the Clinton health plan in the 1990s was designed to, it first was designed to give everybody a card. If you go to Canada, they have a national health insurance plan where everybody has one health insurance, and they actually call it Medicare. But if you live in Canada, you get a card, and the card is your Medicare card, and that's your health insurance plan. Now, the odd thing is they don't have a drug coverage, but the point to that is that's similar to the model that the Clintons envisioned. And by the time 1996 rolled around, certainly by the time 1994 rolled around, they didn't have, President Clinton's administration did not have the support they needed to pass that. We'll next week we'll talk about how they were able to salvage some pieces in BBA 97, but it was built up and then it became really a catastrophic failure. And what the Obama administration learned from that was, instead of trying to do it all, why don't you think about the three blocks: the people who have to use Medicaid, the people who have to use commercial insurance, and the people who are completely uninsured. And then how do you make those three blocks larger? The Obama administration saw an opportunity to expand Medicaid, to subsidize people who could afford insurance, so that the working poor who didn't qualify for Medicaid but had some type of insurance could get a subsidy to help offset part of the cost of it. And then that was intended to also decrease the number of uninsured people. And so by 2009, we started with 67 million Americans. When President Obama took office, the largest number of uninsured Americans in the history of our country was 67 million. Well, by 2016, the number was down to 18 million. And that's a reflection on, again, it wasn't down to zero, but they dramatically reduced those numbers by looking at three targeted groups: people who were on Medicaid. Can you expand that and make more people eligible for Medicaid? Louisiana, as an example, is a state with expanded Medicaid, and Louisiana today has less than 9% of the population who doesn't have health insurance, but more than 20% of the Louisiana population uses Medicaid. And then subsidize people who couldn't otherwise afford their health insurance, or were buying something called skinny plans to be able to have a more comprehensive healthcare plan. Again, it wasn't the silver bullet that gave everybody the health insurance that was envisioned with the Clinton administration, the Johnson administration, and others. But it was certainly, it was taking what you had and making it larger to include more people, and was probably the smartest approach, and certainly got us further than we have been at any point in the last 4 years. So a part of the challenge with the Affordable Care Act debate, though, again, gets back to, can you, again, as a country built around capitalism, so much of what we do is based on financial incentives, and so much of what we do is sometimes cost driven. So much of what we do, though, is also based on the moment. And to be able to see health and wellness pay off, we need you to stay on that insurance coverage for an extended period of time. And yet, if you talk to insurers are constantly seeing a churn of beneficiaries, people that are coming into their system, going out of the system, and going to a competitor. And so when that happens, it makes it very difficult for them to justify those types of expenses. So much so that one key component to the ACA was to develop some incentives in that to expand public health and to promote a healthier population. And again, that's one of the challenges that we face. How do we achieve a healthier population, again, without spending enormous amounts of money? A part of the challenge also the ACA had to deal with is these technological advancements. Again, we do heroic medicine in the American healthcare system as well as anybody in the world, probably better than anybody in the world. If you need a liver transplant and you're at Ochsner on Jeff Highway, your chances of surviving and getting a good liver transplant and having a good outcome and having an extended quality of life is better at Ochsner on Jeff Highway than it is in probably 95% of the hospitals around the world. If you're in a vehicle collision, or you have some type of traumatic injury. You fall from a building 30 feet and you have multiple internal injuries or some type of serious traumatic injury, and you wind up at University Medical Center. Um, your care is provided by some of the best trauma surgeons in the world, and their outcomes are fascinating compared to so many others around the country, and for that matter around the world. We do those things really well. A part of that is because of how much technology we have and how skillful we are at doing some of those things, but it's costly, and we don't have our infrastructure aligned very well. And again, we'll talk about some of those things. The size and the complexity. Sometimes it leads to duplication of services. How do we make sure the things we need are available, and how do we assure that everyone has access to it? Again, I would argue that living, if you are in the greater New Orleans area, you have far greater access to a much higher quality of care than someone in Bogalusa or someone in DeSoto Parish. And you know, now the argument is those people choose to live in those communities, and I agree with that. But how do you extend at least components of quality into those communities without necessarily trying to replicate, you know, an Ochsner on Jeff Highway in some of those communities, or a University Medical Center in some of those communities? And that will be part of the challenges that maybe technology helps us solve through telemedicine and, again, some of the other things we'll talk about. Another challenge is the American public really doesn't understand a lot of what we do in healthcare. At another point in my life, I managed a couple of large paramedic systems, large EMS systems. In one organization, I had 300 employees. In another organization, I had 500 employees. And the consistent thing that I saw every single time in dealing with a complaint from the public had far more to do with perception than it did reality. What I found time and time again, in many cases, people didn't understand what we did. They didn't understand the things we do, but they understand polite, they understand professionalism, they understand how we carry ourselves, how we interact with people. They understand how we establish trust. There are certain things that they do comprehend. We could screw up all sorts of drug dosages. In most cases, they have no idea what we've done. Okay, we know, and hopefully we resolve those issues. Hopefully they don't occur to begin with. But people typically don't know those things. But what they do know and what they do understand is how they're treated and how they're valued. And I will tell you that your role at whatever point you get involved in the American healthcare system is, first of all, to be someone that someone can trust, is to be someone that is professional and courteous in the way that you treat other people. You have to think about people in the context of, you may be seeing them at some of their worst days. And so trying to help them through that particular situation includes this transparency and being sure that they're consulted for decisions, and in talking to them and not down to them, but talking over to them. Other components in terms of how we develop systems deals with a lot of data. And so again, if you're thinking down the road, what type of job would I like to have in the healthcare system? Again, about 75% of the jobs in healthcare are nurses, physicians, respiratory therapists, somebody on the clinical side of care. But the other 25% are the people that are involved in supply chain management. Sometimes it's statistical analysis and quality. Sometimes it's finance. So and certainly data management. I will tell you the people that I've worked around in my career in the hospital world, the people who made the most money, who weren't physicians or clinicians, were involved in the finance side of this. But again, it gets back to what are things that you want to do or need to do. Well, data and statistical analysis, and certainly how we take our data in a way that we can understand what we're doing and how we can improve our process will be one of those important things. So the evolutionary stages of disease: prevent a disease, attenuate disease progression, slow it down or stop it, and then rehabilitate to the highest achievable function. Those are the key components of any healthcare system, and that's really been a key component of any component of healthcare through the ages. It's not just a new phenomena, but it is different because of what type of outcomes we can achieve today. And then natural history of disease progression. We've got that pre-pathogenesis where people are at risk, and then the clinical horizon where medical science is able to detect the presence of a condition. So before the condition can be detected, and then health promotion and specific protections. What we're trying to do there in terms of pre-pathogenesis, how do we promote healthy lifestyles? Maybe that's, one thing I can tell you that will shorten your lifespan by about 10 years is smoking cigarettes. There are a lot of things that we know that aren't terribly helpful to the human body, but the one thing we know that is probably as harmful as anything we will ever do is to smoke cigarettes. And so, in fact, I've had several friends that have died in the last 10 years who I knew 30 years ago. Who I had a friend who, when I worked as a paramedic, we worked 24-hour shifts, and so as long as you're not running calls, at certain hours of the night you're sleeping. And James would have to get up after midnight between 2 and 3 a.m. and go smoke a cigarette. He had that type of a nicotine addiction. James lived to be the ripe old age of 55 before he died of emphysema. And it is important from health promotion to help people understand the consequences of the things that they're doing to their body. A high-fat diet, what type of, but there are some things that are very difficult for people to understand or difficult to navigate. If you live in a what's called a food desert, an area where there's not a lot of fresh food available, the only thing that may be available is McDonald's and Burger King, and there's nothing wrong with eating a meal there once a week. But if that's every day or twice a day, just the nutritional value of what's in most of those meals is worse than bad, and it's not there. It's a lot of hollow calories. It really doesn't promote a healthy lifestyle. And so again, just helping people understand what are the little things they can do to improve their nutrition, whether it's fresh fruits and vegetables, but what type of whole foods can they eat? And then how do we modify behaviors to help people understand that's a good thing to do? And then how do we, from a cost standpoint, how do we provide that in a way so that people have access to fresh fruits and vegetables, particularly in communities that are far more impoverished and far less likely to have access to some of those things. And then the specific protections, and that's occupational health and personal hygiene, but trying to be sure that people understand the value of those specific protections. Vaccinations and immunizations are, it's just fascinating to me how at some level someone can take a piece of information and distort it in such a way that you wind up with young children who are growing up who have not been vaccinated or under vaccinated, or for that matter, adults that have an opportunity to be vaccinated but are not. Um, I'm shocked by the number of healthcare workers right now who have access to the coronavirus vaccine, but have chosen not to be vaccinated at the moment. I, I, I don't, again, things we'll talk about later, but it is important for us to do the basic components of protection, protecting ourselves and protecting our community as a part of this pre-pathogenesis period, primarily known as prevention. And we see prevention as a key component both of the healthcare system, but also public health. And then the secondary prevention, or the period of pathogenesis, that includes the diagnosis and prompt treatment. I will tell you that I do believe in my lifetime, well, it depends on how long I live, but I do believe in a reasonable period of time, we'll continue to see more opportunity to cure cancer. The two critical components to cure cancer is early diagnosis, we found it, and then number two, how to quickly expose the cancer cell in a way that allows the body's immune system to attack it. A part of why cancer is so particularly deadly is there's a lot of times we ignore symptoms, things that our body is telling us, until it's too late, or and then the other piece is a cancerous tumor actually develops a protective shield so that the body's autoimmune system doesn't know it's there. T cell activation doesn't take place, and so I'll show you a video later, not tonight, but at another time when we're talking about this, where Duke researchers, as an example, have used a modified version of the poliovirus to inject that poliovirus directly into a glioblastoma, a certain type of cancer, and by injecting that virus into, so it's a modified virus, so that it's weak, so that the body can protect itself against it. But at the same time, by injecting that virus into the tumor, it breaks down the tumor's shielding so that the body suddenly sees that there's a cancerous tumor there and attacks it with T cells. And we've seen several patients live at and that's normally a diagnosis that you have a 3 to 6 month duration from the time of diagnosis to death. But those are just small examples. Again, whether it's curing or preventing disease, preventing the spread of communicable disease, today our number of flu cases are very low across the country, and it's because influenza is a communicable disease. If I told you to ways to mitigate the spread of influenza, I would tell you to take the flu vaccine, to wash your hands frequently, to avoid being close to other people, to avoid being in crowds. I would tell you to practice good hygiene, and actually I would tell you to wear a mask. Well, what are you being told right now with coronavirus? You're being told the same thing. Quite honestly, what we're doing with coronavirus is actually, in a dramatic way, decreasing the number of head colds we're seeing. There's something called an adenovirus, which is other types of colds or other types of congestion, influenza-like illness, but it's not influenza. But coronavirus, adenovirus, and influenza are the three most common types of infections, and all of those viruses are commonly spread the same way. So the instructions of how to keep yourself safe with coronavirus are actually the same instructions I tell you about the rest of it. I think once we get back to normal, we'll see some of those other diseases come back to maybe not quite as normal as numbers as we saw in the past, but I don't think people will be wearing masks a year from now. And so we'll see more disease, but we won't see as much as we've seen 2 years ago, 3 years ago, simply because of what we've been through as a country. Disability limitation and rehabilitation. We once measured so many outcomes in binary terms. You lived or you died. And it's so much more than that. It's not just binary. You live or you die. It's, if you live, what is your quality of life? And so it is important to know that today, with the technology that we have, the machinery that we have, we can keep you clinically alive for an indefinite period of time. It's not the quality of life I'd like to have. And so, my wife and I have advanced directives. We have something called living will. What are things that we predetermine while we're rational and able to think about these things? Um, you know, Short term, sure, put me on a ventilator. But if I'm on a ventilator for 10 days, or there's no obvious outcome that's going to be a productive outcome. At some point you've got to make a decision to say stop. Let's not do this anymore. And so again, it is important for us to understand the limitations of what our technology allows us to do. But rehabilitation is the same way. So much of this is quality of life. It's not just did you live or you die, but when you were rehabilitated. We also call that restoration. I do a lot of work with the burn care people at University Medical Center now. And there's two big things they do: rehab and restoration. And what that means is, with rehab, are you able to regain a lot of the functions that you had before the burn injury? And restoration, burn injuries can be particularly horrible in how they leave substantial amounts of scarring behind. Because of the type of technology development that's going on with lasers today, so much work has been done in allowing, it's not just, do you feel good about being able to do something? When you look in the mirror, who is the person that you see? Does the person that you see look somewhere close to the person that you saw before the injury? We're getting closer and closer to that every day. The growth in that's been just profound over the last 10 years. And then value, and then optimal health, population health. Again, so much of that is trying to keep a population healthy. When we think about stakeholders, though, we also have to think about who out there has an interest in what's being done with healthcare, particularly as it relates to health policy. Sometimes it's associations, it's the hospital. If I do something that's going to harm the hospitals, all of the hospitals, I assure you, they're going to scream. They have their own political lobby. It's called the American Hospital Association. Federal and state governments, they have to work in partnership. Later, when we talk a lot about Medicaid is a federal and state partnership. It's a federal program that's state operated and state managed, because the federal government puts a lot of money into it, but the state government also puts a lot of money into it. And so there's always this relationship of sometimes the federal government doesn't want to give the state as much money as it may want, or sometimes the state doesn't want to spend the money in the same way that the feds are telling them to spend it. And then different types of organizations outlined here: health insurers and long-term care industry. There are different groups that, again, see a health policy issue in maybe a different light. The long-term care industry is an example. Right now, I'm working with a number of nursing homes as we deal with the pandemic, and just understand one example. If I'm an employee in a long-term care nursing home right now, I have to be tested for coronavirus at least one time a week. And in some parishes where the case positivity rate is high, as an example, Jefferson Parish, it's more than 10%. So every healthcare employee in the long-term care industry has to be tested twice a week. Well, if I work in a hospital, I don't have to be tested at all unless I'm symptomatic. And so just understand that there's competing views of whether that's a good thing or a bad thing. I can't tell you that's a good thing or a bad. I think it's important for long-term care to be tested, but I don't I don't know that I would have the same opinion about the folks in the hospital. I think there probably should be more testing there, but again, that's just a reflection of how policy has developed. And then the pharmaceutical manufacturers. Big pharma plays an enormous role in public policy because they contribute an enormous amount of money to politicians, and politicians have one primary goal in most cases, and that's to get reelected. And so when I said earlier that I don't think there will be the political will to take on certain components in the healthcare world, that's one of them. I don't think there's the political will right now to take on the pharmaceutical industry. Um, there will be small things that they do, but I don't think there will be large things being done. And then the research communities are certainly important. Um, and the rural health networks. So one particular component of the rural health network is actually, let me go back. One key component of the rural health network is the critical access hospital. We'll talk about critical access hospitals next week when we talk about how things developed during the Clinton administration. But it is important to recognize that rural healthcare is a constant battle to keep it not necessarily profitable, but from being a loss leader. As much as larger hospitals right now are in some cases profitable and in some cases very profitable, rural hospitals in most cases are losing money, in some cases losing a lot of money. And so how do you negotiate and keep a rural hospital open is a constant challenge in some of the rural communities. Again, 1991, there was a critical access support that was created. It was something called a peach and an each. It's not a big deal, but it did change. I don't have it here yet, but it changed in 1997 with the creation of the critical access hospital. Again, stuff we'll talk about later. The ACA did shift some focus from curing the condition to trying to prevent the condition. We see that through some prevention strategies. Again, there's a myriad of efforts going on out there, but the intent is to try and prevent conditions from occurring and do that through health promotion. But again, that's not always gone as well as it could. We get back to the tyranny of technology. Again, the challenge is, what does it cost and what's the value of it? We have spent a lot of time, effort, money, and energy on technology, but done so in a way that it's important, and in many cases it's a blessing to have, but at what cost? And we'll continue to talk about, both how reimbursement is driven by some of this, what's the value of it, what's it worth, and then some of the social choices of healthcare. Part of the challenge that we have is, again, trying to help people understand what are things that they can do to keep themselves healthy. What are things that, as an example, I don't have a particular position. A number of states right now are opening up their laws as it relates to commercial use of cannabis, marijuana, and the real challenge that I have with that is we don't have the science to help us understand whether that's a good idea or a bad idea. But the other side of that argument is we've also not done a good job of studying it because the laws didn't allow us to use the scientific world to study and understand the use of marijuana. So, I do believe, cocaine as an example is a Schedule II. It's a legal drug. Now, it's legal only under the context of prescription and under certain settings, but it allowed us to study it and understand what its uses and what its limitations are. And we don't really have nearly as much of that with marijuana. What we've wound up doing is opening it up in such a broad way that we're going to see a lot of science out of it. I'm not sure that's the ideal way to do it. But nevertheless, some of our social choices do lead to how that impacts the healthcare system. And then part of this is understanding how our population is aging and the impact of the aging population. You know, when we get to the point that more than 20% of our population is over 65, the cost of Medicare, I'm not sure is going to be manageable in such a way that we don't wind up doing something different. Do we push up the age of Medicare eligibility? Do we increase the copay? But there will be some things that will have to happen in the coming 20 years, the next 20 years, to help offset the cost of what is an aging population in the US. And then the Medicaid money. How do we distribute the Medicaid money? Again, the Affordable Care Act did a good job of expanding Medicaid, at least to states that wanted to participate in Medicaid. But we'll also talk about how, where states have chosen not to expand Medicaid. I think that's rather foolish, but nevertheless, we'll talk about why some, at least political philosophy is there for not expanding Medicaid. And then access to healthcare. One of the most important things that we'll ever do is advocating for people to have access to healthcare. It is important for people to have access to healthcare that is safe and effective and affordable in a way that reflects what they're capable of paying. And then that quality of care. We will talk about that last bullet point down there, pay for performance measures. What are steps being done to, again, eliminate errors and do that with financial reward, and also do that with financial penalty for organizations that are not doing a good job of that. And then conflicts of interest, again, trying to clean up some of the conflicts of interest. A majority of the people involved in healthcare are involved in healthcare for doing the right thing for the right reason. But there's always somebody who looks at ways to scam the system, to game the system in a way that they can make the most money out of it. And there's a fine line between being profitable and being greedy. And again, we'll see some of those cases later on. And a part of the Affordable Care Act included something called the Sunshine Provision. And then what are ways that, again, we can help people understand where those ethical boundaries are and work through some of those ethical dilemmas. But then the continuing challenge continues to be, how do we look for ways to manage the healthcare system in a way that's effective for everyone and accessible to everyone, and yet cost effective. And the cost effective piece will be one of our largest things to do. And then if the Affordable Care Act was struck down, there is one piece of legislation that has caused the Affordable Care Act to find its way back to the US Supreme Court. Is it possible that they could strike it down? I think it's unlikely, but if they did, what they may do is set aside a piece of the rule without setting aside the entire rule. But just understand that there are parts of the Affordable Care Act that, whether you understand that's a part of the ACA or not, it's a big deal. The public exchanges allow people and small businesses and individuals to buy policies that are consistent and affordable that otherwise weren't available to them in 2009. The advanced premium tax credits and the loss of subsidies allow people who don't have as much income to be able to still buy health insurance at an affordable level. Medicaid expansion, as I say, Medicaid expansion brought 12% more of the Louisiana population onto some form of health care. It reduced our insured population by 12%. That was a big deal. This protection for patients with pre-existing conditions. If you know of somebody who's had a stroke, who has diabetes, who has something that in many cases may not be of their own doing at all, but before the Affordable Care Act, those people could be excluded from buying insurance if they change jobs because they had pre-existing conditions. The community rating, we'll talk about later when we're in insurance, and then this loss of extended coverage to age 26 for dependent children. That was a big part of the Affordable Care Act. Again, the ACA has done a lot of good in the American healthcare system. There are places that it does need to be improved. There are places that there are gaps in it. But I'm not sure there's a lot of political will to make those types of changes. But there are still places that can be tweaked, even if the only people interested in tweaking it right now maybe one political party. Again, the best solution comes from all viewpoints. I'm just politically, I just don't know if we're going to be there yet. I hope we are, because I do think you need Republican input into this to make this more effective and more accepted across the country. And with that, I'm 2 minutes over my time. I'll say, do you have any questions?
I don't have any questions, no.
Okay. Well, so what I would tell you is, again, before you get ready to take the quiz, I would encourage you to go back and look through this one more time. And again, I don't have any heartburn over you looking up an answer. You don't have enough time in the quiz to look up every answer. But I want you to learn the material, and if that helps you learn the material, that's okay with me. Again, by the time we get closer to the end of the semester, you'll have about a minute per question, and in some cases 45 seconds per question, and that reflects the fact that you should be building upon what you've learned each week. And so, hopefully those things will sort themselves out. I want you to learn the material. When you leave this course, a lot of what you do, particularly if you're in healthcare, whether you take another class in the healthcare management program or not, a lot of what you do will be built upon some of the things that you learn in this course. And so it's far more than what type of score you achieved, it's what did you retain. And so that's the aim of what I'm trying to accomplish. And I hope that helps. Well, folks, I don't have anything else to say. If you don't have any other questions, I'll tell you good night, and I will see you next week on Zoom.
Yeah, thank you. Have a good night.
Sure, you too. Good night.